Hi, this is Erica Fishman from Minnesota Department of Health, and welcome to this webinar on health literacy. I'm the Transitions of Care Coordinator and for the stroke program. During this meeting, for those of you that are on WebEx, we encourage you to use the chat feature as an additional way to communicate with us besides just speaking up and asking questions. If you do speak up and ask a question, we ask that you state your name and what facility you're from. We also will be recording this meeting today. For this webinar, we'll finish with introductions. We'll have 2 presentations, time for discussion, sharing, questions. We have two presenters today. Janelle Lamont is here from the Minnesota Department of Health, Division of Health Promotion and Chronic Disease. She works with our oral health program. She's chair of the Center for Health Promotion, Health Literacy Advisory Committee and has extensive training on health literacy. Following her presentation, we will have presenters from Essentia Health Interventional and Vascular Neurology Department, Diane Roach, who's the Stroke Program Manager, Gwen Crespin, Neurology Department Manager, and Pamela Hermes, who's the Physician Assistant, and Tracy Udine will be splitting that presentation. Just for a few program updates, we just want to remind you this is part of our monthly webinar series, so we encourage you to save the dates. Our last one for this calendar year will be December 19th, and then we'll start again with the next year on January 23rd. On February 27th will be our next Transitions of Care webinar. I'll be sending out information on that, and that one's going to be focusing on nurses' role in transitions of care. We have recorded all of our webinars, and these are the topics for the ones related to transitions of care. Please feel free to email me if you want more information on how to link to the webinars, you're interested in receiving a every couple of months email on transitions of care, or if you have comments or questions about transitions of care. Before we go any further, if you have any questions or you can't hear us in the room here, please send a message in the chat box and we'll work on being better able for you to hear us. So the topic for today is health literacy. One of the reasons we picked this is because last month was Health Literacy Month, and as you can see by this slide, health literacy is very important to increasing the health of individuals and avoiding some of the problems that come when you work with low literacy individuals. So now I'm going to pass this over to Janelle, who is going to do her presentation.
Thank you, Erica. So it's a pleasure to be here today to speak with you on health literacy. This is a topic that's very near and dear to my heart, and also about clear communication techniques that you can use in your practice with patients.
You just have to click the arrow up at the top.
It should be not working right now.
We're just having a little technical. I've been moving it here.
Oh, yeah.
Okay, so what is health literacy? Well, there's not really an agreed upon definition for health literacy, even though this has been a topic that's been around probably since the 1980s or early 90s. But with that said, basically health literacy involves a bunch of skills that you need in order to navigate the healthcare system. It requires you to be able to understand and to be able to access, know where to get health information, be able to understand what you read or hear, be able to evaluate whether that makes sense for yourself and to be able to apply that. I really like the definition from the Minnesota Health Literacy Partnership, because it doesn't just place onus on the patient to understand health information, but really also on the healthcare providers and the systems. So their definition is it's a patient's ability to obtain, understand, and act on health information, and the capacity of healthcare providers and healthcare systems to communicate clearly, educate about health, and empower patients. It really is a critical component of health equity. Disparities can happen if you're not able to understand your health information to be able to act on that information. So really that's the big umbrella is health equity, and health literacy then is the social determinant of health. Underneath health literacy are the constructs of plain language, patient-centered communications, numeracy, and accessibility, which I'll talk about these a bit more later. Plain language basically is making sure that you're avoiding jargon when you're speaking with patients, that you're using plain living room language that everybody can understand. Patient-centered communications involves culturally competent communications, so making sure that when you're speaking with patients, you're speaking to them as their individual and understanding their background and culture so that it's culturally and linguistically appropriate. Numeracy involves how we're talking about numbers, so that might be patient's medication, how to provide proper dosing, for example, or talking about risk communication and statistics related to their disease. And then accessibility is in relation to written documents, more or less electronic documents, making sure that they're 508 compliant so that people with color blindness or people that have to use electronic screen readers can still read and access that information. So when we're talking about plain language, again, we're kind of avoiding those medical and jargon terms that we use as health professionals for things that make more sense. And it's not to say that you're making the information, dumbing it down or making it less accurate, but you're just making it accessible to everyone. So for an example, instead of saying a neurologist, you could say a brain doctor. And things that we take for granted like negative, positive results. Just because something's a negative result doesn't mean that that's necessarily a good thing. So saying things in terms of a good or a bad result makes more sense to people. Also, in relation to equity and health literacy, again, making sure that your information is tailored to that particular individual. Just making sure that you're understanding their culture and their background. But then also knowing that people are indeed individuals and they might not necessarily ascribe to certain cultural attributes. Here's some examples of how health literacy is applied in communication. It can be written, verbal, or nonverbal communication. So things that we might think about might include things like discharge instructions, informed consents, any kind of health education that you provide. So why should we care? Why should we focus on health literacy? Well, it really does impact patient quality of care, safety. It's attributed to 18,000 patient injuries and 7,000 deaths every year, and it also costs the U.S. healthcare industry between $50 and $73 billion each year. There's also components of health literacy in things like the Affordable Care Act and the Plain Language Act, as well as the culturally and linguistically appropriate services in health and healthcare. And also we have moral obligations to provide clear communication. A lot of us had to take an oath to do no harm, so that's making sure that your patients understand what they need to do to be healthy. Low health literacy can result in an array of issues, including less use of preventive services, low treatment adherence, not being able to manage their chronic conditions, unnecessary emergency room visits, and longer hospital stays. And on the more far end of that spectrum could result in death. So you might be surprised to learn that nearly 9 in 10 adults in the United States have insufficient health literacy skills to be able to adequately manage their health care and the health care of their family members. This is coming from a 2003 national assessment of adult literacy skills. Unfortunately, they don't do this assessment anymore. That got replaced by an international study by the Program for International Assessment of Adult Competencies, which looks at adult literacy skills, numeracy skills, and also being able to navigate in technology-rich environments. So this bar graph here shows that the United States falls well below average in terms of literacy skills. and even worse in numeracy skills, only surpassing Italy and Spain. Here's a great website that you should check out later. This is put on by the University of North Carolina, Chapel Hill, which basically mapped out that 2003 national study of adult literacy skills. So you can see by your zip code or your county what type of literacy skills people have at the population level. Some risk factors for low health literacy include being an older adult, having limited English proficiency, being socioeconomically disadvantaged, and having chronic and severe health conditions. But with that said, anyone could have low health literacy skills at any point, even people who are well educated. For example, let's say, in your work, someone just had a stroke. And family members are obviously going to be involved in that too. So having that kind of level of stress can really affect how you're perceiving and receiving information. So usually I ask audiences here, who here has low health literacy, and see if people can guess. But really, as my point was before, is there's really no way to tell just by looking at someone. And so we make sure that we're always using what's called a universal precautions approach when we're communicating, and just assume that everyone enjoys clear, plain communication. So with that said, there might be some quote-unquote red flags that might clue you in as to whether or not someone might have difficulties understanding health information. For example, perceived resistance to some of the recommendations that you provide, someone that has no questions, someone who might make excuses if you give them some literature on health information, for example. They might say, oh, I forgot my glasses, or I want to bring this home to review later. Somebody who might frequently miss appointments or tests and are non-adherent to medication or treatment. So here's a basic list of some clear communication or patient communication strategies that you can use in your practice. One of the most important things is to create a shame-free environment. If somebody's not following goals or recommendations, don't assume it's because people aren't caring about their own health. It's better not to shame them or criticize them, but rather to try to speak with them more in depth to try to figure out what barriers might exist for them being able to achieve some of these goals. Again, making sure that you're using plain language or living room language. One statistic I heard said that about someone on average probably understands or remembers about 60 to 80% of what's discussed in a clinic visit. So it's important to really keep it simple and focus only on the need to know and need to do action items. You can also show people how to do certain instructions by demonstrating with pictures, other illustrations, or models, being sure that you're using clear, easy to use, and easy to read forms and educational materials. And one of the most important things you can do is use a teach back or show me method for communication. So that means after you've instructed them on something in particular, you want to make sure that you double check that they understood what you just said. So you can say things like, okay, now just to make sure that I have communicated as clearly as I could you show me how to do this? Or could you tell me what you're going to do when you go home tonight? This next slide shows kind of an example of something that might be written or communicated with a patient on stroke recovery or a prevention plan, especially with family members. So again, just keeping things in plain language and real clear, communicating about considering what kind of needs that they have in order to do their daily activities, creating that routine, and if you need help with family members, for example. One of the most important things, too, is with medication. So this next slide here shows a great resource by age, RQ, which can help people to understand their medication. A lot of times it can be confusing with the medication dosing or with the names of it. So this is just a real nice way of showing people how they can manage their own medications. And then here's a great way that you can promote engagement with your patients as well, making sure that patients know to feel comfortable to ask questions, and that at the patient visit they should know that they should at least ask 3 questions if they haven't already been covered, which is, what is my main problem, what do I need to do, and why is it important for me to do this? And then lastly, I just wanted to share this nice blog that I found on ME Solutions, which is talking about health literacy lessons learned in Chicago primary stroke care facilities. And with that, what questions do you have?
So this is Erica again, and we're going to hold the questions to the end so there's enough time for the presentation from the Essentia staff. But I appreciate, Janelle, all the information that you provided to us. I think it's going to be really helpful. And we'll be sending out the slides with an evaluation form for you to complete so that you'll have them to look at too and can access the information that's in them. So with that, I'm going to pass this over to the St. Mary's Essentia team.
You are unmuted. Oh, you are unmuted again. Now you're unmuted.
Can you hear us?
Yes.
Okay, great. My name is Diane Roach. I'm the Stroke Program Manager here at St. Mary's in Duluth, and I'm here with my stroke team. I have Tracy Udine, and she's an advanced practice nurse that follows our patients from the hospital to the clinic. I have Pamela Hermes, a physician assistant that works with our stroke patients in the hospital setting. Gwen Cressman, who's been our administrative lead for our Transitions of Care project, and Stephanie Keyhole, who is our stroke patient navigator. And so with this project, it really started with our Stroke Transitions of Care project. Our initial goal was to improve stroke transitions of care, improve quality of care, quality of life for our patients who've had a stroke or TIA, also reducing avoidable complications, adverse events, and readmissions. And so with this project, patient education was one of the main things that we wanted to work on. We realized that patient education was a key point in our patients' ability to recover from stroke. We knew our existing tool needed to be updated. It was a few years since it's been updated. We also had a PA student that needed a project, so we kind of wanted to utilize that opportunity to help us complete some of this work. We also wanted patients to understand, what kind of stroke they had, their testing, their medications, risk factors, and really understand what's going on in their hospital stay. And then we also found out that we had different education tools in our hospital compared to what we had in our primary care clinics, compared to what was available in the neurology clinic, in our rehab setting. We kind of have different tools, and we wanted kind of a consistent message across the continuum of care for our patients. So we got together a bunch of stakeholders. We identified people who wanted to develop and update their stroke education. These stakeholders were not only from the medical team, but included past and current stroke patients and their families as well. We also wanted a team that was invested and wanted great outcomes and excellent stroke patient education. So here's a list of the stakeholders. Like I said, we had patients, patient partners. We utilized our patient education departments quite a bit, as experts in readability and health literacy. And then also our stroke team, rehab, like I said, primary care clinics. We utilized our hospitalist department as well and our nursing practice councils. Our vision included improving our patient education. We really wanted an interactive tool, and this was evident in the literature. When we did our literature review, it really needed to be interactive with our patients. So there's pictures, we could circle in the book and make it very interactive with that patient and family. We also wanted education to start on admission and then continue throughout the hospitalization and then through the primary care clinics and our stroke clinic as well. We wanted to utilize a teach-back method and ensuring patients that were involved could demonstrate their understanding or lack of understanding of the education. And then we also wanted it to be interdisciplinary, utilizing all of our team members, including our therapy colleagues and our nursing staff. And then finally, our education, we wanted to serve as a communication tool between all members of the healthcare team, including the patient, primary care clinics, and our rehab colleagues. So what we did is we incorporated multiple steps in this process. Like I said, we identified the need to update our current education. We wanted it to be interactive, and we worked with our patient education department to assess for plain language. They put it at a 4th to 6th grade reading level. We kind of updated our tool along the way as we worked with multiple different teams. We also utilized patients in the hospital and trialed it with patients in the hospital and patients in the clinic using the teach-back and making sure that they understood what was written in the book. We also enlisted unit-based practice councils to review the education, and our interventional and vascular neurology team to make sure everything was best practice and written appropriately. CARF rehab program also took a look at it because we wanted, again, the same education in the hospital as rehab. Primary care clinics had knowledge and information for us for the binder, and then we made revisions again along the way. And then our final step in the process was really sitting down with our patient partners. We had a patient and also a family member that we would use along the way. And they also brought the patient education binder to our stroke support group. And, you know, again, we made final changes utilizing feedback along the way. I'm going to turn it over to Tracy Udine, who's been more involved with the actual patient education piece, and so she's going to kind of talk about our patient and family engagement.
Thank you, Diane. Well, as everyone knows, patient and family participation in stroke education is very important. Our inpatient interventional and vascular neurology team meets with our patients and their families every day. In addition, our colleagues from our other disciplines meet as well. We use that binder for teach-back, and we make sure that at discharge the binder is completed. We make sure that we document the stroke diagnosis, the imaging results, the lab results. We identify the patient's stroke risk factors, make sure they understand their medications and the rationale of the medications, and that they also have a list of all of their follow-up appointments. We then place this into a specially essential health bag, and we stress the importance of the binder and the bag to the patient and family and ask that they bring these items to all of their follow-up appointments. At these follow-up appointments, the binder is updated again to reflect the patient's recovery process. And then Steph, our stroke navigator, and myself, we will provide a follow-up phone call to make sure that our patients are at home, that they have been able to obtain their medications, that they understand them. We also want to make sure that they have transportation to their appointments, making sure that their symptoms are slowly recovering, that they haven't fallen as well. We really try to tailor the plan of care and recovery to each individual. On the next slide, you'll see here that we have a little picture of our bag and our stroke binder education. As Diane had stated earlier and Janelle had spoken about teach-back, we have pictures here where we can circle and color and kind of outline where the stroke is. We circle their symptoms. We circle their risk factors. Often, too, when Stephanie and Pam and I are at the bedside educating our patients, we'll encourage them to show us where their stroke is, or we might have them write in their own handwriting the type of stroke they had on those imaging pages. What's very exciting for us is that our newly updated stroke binder has had an impact. First, we have increased stroke awareness across the continuum of care. from the hospital through to the clinic follow-up. Secondly, our stroke binder has reinforced community resources that are available to our patients and their families. When Steph and I are talking to these patients and family members on the phone, we refer back to the resource section in the binder regarding transportation, support groups, other resources that are available. More than anything, we feel that we have strengthened our transition of care program. We've been able to improve the communication and the plan of care for our stroke patients from the time of diagnosis to follow-up and even beyond. We're seeing these patients bring their binders to their follow-up appointments at 3 months, 6 months, and even as far as a year out. We'd like to end on a positive note regarding our stroke education with a comment from a stroke patient who had partnered with us in revising our education. The patient stated, quote, "In the hospital, I didn't always understand everything that was being taught to me, as I didn't always understand the language used, but would nod my head like I did understand. When I went home, I found the stroke education book so helpful as it was written in a way that I could understand," unquote. So we're certainly open to questions, as well as Janelle.
So we have a few minutes now if you have a question. If you want to ask the question, you can either type it into the chat box or to unmute your line, you can press *6. So if they have questions for Janelle or for the Essentia team.
Somebody asked, did you have any problems with Joint Commission with the patient education binders? They had been told at their facility that they can't.
This is Diane at Essentia. We have not had any problems with Joint Commission. They've actually liked to see individualized education and individualized risk factors, and we haven't had any issues with that at our facility.
Somebody else asked, do you newly print documents to put in at the time for education?
Yes, we actually decided, we looked at several different options, a bound book, a binder, and different options for printing, and we actually went with a binder so you can individualize and print out additional pages. In fact, rehab, what we send to rehab with our patients, sometimes they'll add additional sheets, especially there, you know, to individualize that patient education.
This is Tracy. In addition to, now that we are starting to do thrombectomies here at Essentia Health, if a patient has a thrombectomy or they have a cerebral angiogram, we now include that information in their binder for them.
We have time for about one more question.
Somebody asked, did you have any metrics that you looked at for the impact of the binder, for example, post-hospitalization falls or readmissions?
We do measure our readmission rate. It's been a little bit since I've looked at it, so I guess I can't speak to that at this time. Our readmission rate was kind of low to begin with, but you know, we will be continuing to look at outcomes with our transitions of care project. I don't have that in front of me today, but that is something that we are looking at.
Thanks everybody for presenting today. We're at the end of our time. We're going to be sending out the evaluation survey, as I stated earlier, and we'll have the slides attached to that. So please, if you can fill it out and send it back to us, that would be great. We used information to planning for future webinars. Thank you for attending today.
Thank you, everybody.
Thanks.